From the Library of Congress in Washington, D.C.
Peter Kramer is our guest. He is a columnist. He is a novelist. He is a psychiatrist on the faculty at Brown Medical School. But as he says in his new book, he's basically known as the listening to Prozac guy. All of you who are here, I would say, I'm willing to bet, have read this book. And his new work is called Ordinarily Well. It's a follow-on to the bestseller, Listening to Prozac. And please join me in welcoming Dr. Kramer. Can you hear us now?
Yes. Shall I put this, is that necessary or no? It's still not on? No.
Is it here? Hang on. Here come the technical folks.
Science. Better? I want to give
Does my microphone pick up Dr. Kramer's voice?
Well, even I can tell. All right. So I've been to some of the other sessions here where the yet better selling and more honored authors are speaking, and they all start by saying how they were saved by reading, how the library card really brought them out of some small community into the world. And it certainly is true for me. I'm a child of immigrants. My mother was not satisfied with the public library in our community and would drive me across town to another library so we could take out good enough and well-curated enough collection of books. So I'm honored to be at a celebration of reading. This really is, I know, important in all your lives and a cause. Literacy certainly is a cause. So just thought we'd say that before we talk about a book. Yes.
Terrific. Thank you. After reading your book, I guess the question I most want to know is why this book at this time? 23
Yes.
years after your bestseller,
Right.
at a time when 1 of 8 people in America is using antidepressants.
Right.
Why a defense of Prozac and antidepressants?
But most of my books come the way writers' books do, out of some inspiring thought, something that just needs to be written that is writerly, some observation that needs exploring and amplifying. This really is a cause book. This is a book I felt had to be written for the sake of patients, which is not a comfortable starting point for me, and maybe it's why it took me a little longer than some of my other books. But I tell stories at the beginning of the book about people who really need antidepressants, who either have not been prescribed them because their doctors have doubts that have been aroused by what I think is spurious research that claim that these antidepressants, and in a minute we'll say a little what depression and antidepressants are, but spurious research that says that these medicines are a little more than placebos with side effects, or who are doing well on antidepressants in ways that are important and are cast into doubt. Should I continue taking the medicine? Is it really a placebo? And I'm not, by the way, saying that everyone who's depressed needs to be on an antidepressant or everyone who is doing well on an antidepressant needs to stay on it. Just that first question, do they work at all, really can be discarded. And I think both researchers and the press and the media have thrown that into doubt in a way that is dangerous to patients.
But as a psychiatrist,
Yes.
it's quite obvious antidepressants work.
Right.
How have those doubts been raised?
So, of course, doctors see these medicines work. And the doubt that has been raised isn't whether people get better on antidepressants, but whether they get better based on the inherent efficacy of the medicine. That is, you could get better just because of your faith in the doctor and your faith in pills, or you could get better because these medicines really work. That is, they're chemicals, they're taken into your brain, and they do something that's useful for people with mood disorders. So I want to just say, because I have talked a lot to the public, and I know that not everyone knows this, what depression is. When we say depression, what we're talking about. So depression isn't just ordinary sadness. It's a syndrome. It's a constellation of symptoms. It's a disorder that's been recognized, since the time of Hippocrates, starting under the name melancholia. And you know it when you see it. Lately, it's been defined by symptoms, right? So people are sad, they can't experience pleasure, they're slowed down, they're apathetic, they may be suicidal, they may have problems with sleep and appetite, low self-esteem. But it is those things in a way that coheres and makes it hard to function in life. And, at the extreme, you can think about Picasso paintings or Dürer etchings where people are wringing their hands and looking at the ground, and they're emaciated and almost starving themselves to death and obsessed with negative thoughts. But there's a range of depressions, and some which are less recognizable in that way are still very destructive in life. And I think when you're in the presence of a depressed patient, you know pretty much what that is. It's not ordinary sadness. And the antidepressants are medicines that humankind has had access to only for the last 60 years. Since Hippocrates, doctors have wanted to have chemical approaches to depression. The first antidepressants were developed in the late 1950s. The concept that a medicine that we had to hand did this was really elaborated in the 1950s. And then in the late 1980s, in Europe and here, we had this newer group of antidepressants beginning with Prozac, and names that are at least familiar to you are things like Zoloft and Celexa, Effexor, Lexapro. That's the class of medicines we're talking about.
Is it true that we still don't really know how they work?
It is true.
How can that be?
Well, the brain is very complicated. In listening to Prozac, I quote a scientist who says, if the brain were simple enough for us to understand it, we would not be complex enough to have that understanding. We know a lot about antidepressants. We know at the first level that these medicines affect patterns of transmission in the brain, the way cells signal one another with chemicals. And we know that these medicines restore resilience in the brain in some quite general way. So they make it possible for people to make new cells in the brain. Something we've only known for about 20-odd years is that the adult human brain continues to make new neurons in certain parts, and they allow the brain to make new connections between cells. And those things are really muted in depression. Depression is a multi-system illness that affects the brain's capacity to learn, but it also affects bone, blood elements, hormonal glands. So this is a body-wide disorder, but at the core, we have problems with the resilience in the brain, and the medicines restore that. I start the book with an anecdote about a friend of mine who sadly had a serious stroke, and it turns out that this kind of stroke, there's more recovery from this kind of stroke if you're given antidepressants early, not because they fight depression, but because they restore the brain's ability, apparently, to elaborate connections between cells in this way. And this friend of mine, this patient, was not getting antidepressants because of this sort of created prejudice against them. And that really was the trigger for my thinking about writing a book like this.
So we don't know exactly how they work.
Right.
But you, as a psychiatrist, and somewhat rare among psychiatrists, you do both talk therapy and prescribing
Right.
of antidepressants. So, and you obviously see that all of this works.
Yes.
So where on that scale between all medicine and all talk therapy
Right.
do you lie, and how does the patient pick his or her place on that
Right.
scale?
So it turns out that depression is a relapsing and remitting disorder. It is chronic. People who have had a few episodes are likely to have more, and that the later episodes tend to be graver. They have more serious symptoms. They last longer. They have more trouble responding to whatever intervention we make. So we like to interrupt depression. And to me, the measure of worth of a treatment in depression is that it works. So that the case is made for exercise and meditation and yoga and religious counseling and so on. And the question is, are you getting better? And if you're not getting better, the best tested remedies are psychotherapy and medication. And I usually start talking to people. I want to know what's going on. And that in itself seems to have some mitigating effect. And my measure as a doctor, and I think the doctor really is the instrument here, is worry. If I start worrying that this is really solid, that I'm not budging it, that things are getting worse, we're falling behind, I do tend to turn to medication, and it tends to work. There are, I don't know how well you think these medicines work. There's a figure going around that appears in the press lately, and part of this book is quite critical of the press and how they look at research. But the figure is 30% that antidepressants help 30% of people. Well, that number, which is wrong in three ways, comes from a study, very terrific study, sponsored by the NIMH, Institutes of Mental Health, that looked at people who had been depressed on average for 15 years, were in a 7th or 8th episode of depression. That episode had lasted 2 years. Most of the patients, in addition, were alcoholic or had a second mental illness. And in those patients, the first antidepressant tried at ordinary doses caused a remission, that is, the episode of depression ended in 30%. To me, that's actually an astonishingly good figure. Why hadn't those patients gotten better already? Half of them lost half their symptoms. If you look at an unselected population, primary care doctors, patients coming in, you see much higher levels of response. So we're not really discussing, do people get better on this? There was a Swedish study looking at primary care populations, non-suicidal people, and by 6 months, 90% of them had lost half their symptoms. So, people are very responsive to these medicines. And the controversy that the book's about is this question about whether depression is also very responsive to placebo pills. I think it's not, but it's kind of a complicated story. And I try to tell it complexly through stories from my practice, stories about the history of psychiatry, and also some introduction to sort of basic statistical approaches to research. How do we measure depression? How do we measure change? How do we combine studies? What makes us think that a medicine is working? And how do doctors outside psychiatry, treating things like diabetes and asthma and so on, think about their treatments? How do we compare?
So at the risk of asking you to boil down your entire book,
Right.
why doesn't the placebo hypothesis hold up?
Well, placebo is very complicated. You go into a study and all sorts of things happen, right? You get a lot of attention from doctors, time passes, you return to employment, whatever it is. So you need to say what would happen if we hadn't given the pill. So some people are on the pill, some people are not on the pill. Everybody gets a little bit better. The people on the pill tend to get a lot better, and the pattern of recovery is really different. On placebo, often a few symptoms get better, and a lot of people on medication, some really don't get better at all. They don't even enjoy that little placebo effect. They have side effects. They're troubled by being on the medicine, and many of them get a lot better. And so the question, first of all, is what's going on in the, quote, placebo arm of the trial? Are people responding to their beliefs about the pill, or is it all the support? And then the second question is, what does the medicine add? And it turns out the medicine adds a lot. And I call the book Ordinarily Well because the level of what's added is at the level of what's added by most treatments that doctors give for most common chronic ailments like depression.
I was going to ask you, in fact, the very next question. In the first book, you coined the phrase better than well.
Right.
And I assume Ordinarily Well came from there.
Yes.
Could you tell us about that?
Right. So listening to Prozac is really about the biology of personality. And it turned out when these new antidepressants became available, they didn't just get people better from depression. I had patients coming in who'd say, I'm past that episode of depression, but in addition, I'm less socially anxious, I'm more comfortable, I seem to be better at my job, better at parenting. And I called that phenomenon, or one of my patients really called it better than well. He said it was better than baseline. And I asked other doctors and was writing columns for doctors at the time, and, are you seeing this? And then I wrote about why the biology of these medicines might lead to that sort of result. And it was a worrying book. That is, if we could reliably influence personalities in ways that the culture rewards, might doctors overstep in certain ways? And one reason I thought I in particular ought to write this book, that book was about tweaking personality with medication. It was worried, was to say those worries don't really extend to the core uses of medication. Depression is a really destructive ailment. It's very common. We have tools to treat it. If they're called for, we ought to be using them.
We haven't talked about side effects, which are a huge issue in antidepressants. One of the things I didn't know when I read the book is that when Prozac came out, you point out that it was adored not so much for its efficacy, but for the fact that it had so many fewer side effects.
Right.
Can you tell us about antidepressants and side effects, and how much better are we doing these days in terms of allowing people to be on these medications without these side effects?
Right. So the early medicines that I write about, one called imipramine, worked. They treated depression, but they were dangerous in overdose. You could commit suicide on them easily. And they made people feel drugged. They gave you a dry mouth. They affected the ability of your eyes to accommodate, moving between near and far vision. They gave constipation, urinary problems in men particularly. People really felt they were on a drug. And I think when medicines like Celexa and Prozac came out, even doctors didn't understand how important it was that they had a different side effect profile. Now, these medicines have lots of side effects, but people on them sometimes don't feel, especially if they're on a drug. And if you're going to be on a medicine for, say, 6 or 9 months, taking it every day, it's very important that you just feel well, not that you just feel less depressed, but that you can go about your business not being always aware that you're on a medication. These medicines have side effects. One that is very much of concern to us and is written about a lot is the possibility that people will get more suicidal, and even that people who are depressed but have not been suicidal will, for the first time, feel suicidal on medication. It turns out this was an overlooked side effect of the earlier antidepressants. Once this became clear that this was a possibility on the new antidepressants, it was found in the older antidepressants. It was found in a lot of the drugs given for epilepsy. It turns out to be true that a number of classes of medication that affect transmission in the brain have that risk because we're complexly wired, and the medicine, it's people who are set up to have these transmitters do one thing in their brain. Not everyone has that same pattern. So we watch people very closely when they first go on these medicines. They can cause people to have less sexual interest, the newer antidepressants, be slower to have orgasms, very troubling, less common in young people, very troubling, especially to young people. And then lots of the ordinary side effects that you see with many medicines like nausea, headache, and so on, while not especially common, are possible side effects to these medications. So they're not without a price. And using them for a long time, they're late-appearing side effects. People can actually get more apathetic, and it's sort of an art for doctors to distinguish between apathy as a side effect, which often can be handled or reversed, and a return of the depression. So these are medicines that are best used expertly.
And yet it appears, and it's quite common for people to be on antidepressants for many, many years.
Yes.
And it's okay.
Right. Well, we don't know. I mean, we've been sort of lucky. There were lots of worries about certain biochemical events that might happen that would make these medicines dangerous in long-term use. That doesn't seem to have emerged. But we don't know. I mean, there's sort of a very large experiment. These medicines were developed for people to be on for 6 or 9 months. If people have had 2 or 3 episodes of depression, especially if they've been suicidal, their doctors tend to keep them on these medicines for a long time. We don't know enough about what that does, but we do know that these medicines work for a long time. There are experiments where you have people on these medicines, and you then, after a while, put some people secretly, with their permission and awareness of the overall experiment, on placebo. And it doesn't matter how far out you measure this, weeks, months, years, people on placebo are 2, 3, 4 times as likely to become depressed again as people who stay on the medicine. I do take people off antidepressants all the time, and I take them off earlier probably than the scientific literature says. I like to watch them closely. I have the luxury in a sort of carriage trade private practice of having people come to me often enough that I can watch and institute what's called rescue, that if people start slipping, we reinstitute antidepressants fast. But the truth is that depression also is harmful, and that being on the antidepressants does seem to prevent the progression of depression as a chronic disease.
You raised this in the book, but let's say I came to you and I said, Dr. Kramer, the antidepressants you gave me are making me feel so much better. How much further can you take me towards feeling really good? Right.
So I think our goal is ending an episode of depression. It really is not revving people up or making them more fluent in certain ways. But I mean, that is a tough topic. People who say, really, I'm just functioning better as a parent. I want to stay on this medicine, or I want to go back on it. How do we deal with that? And in listening to Prozac, I write about what I call diagnostic bracket creep, that once we have a tool to hand to treat something, do we tend to expand our definitions of illness to tell ourselves as doctors that we're treating illnesses. Let me say something, because we've been talking in theoretical terms. This book and the use of antidepressants and psychiatry in general is about people. These are ailments that really blight lives. And I try to make this book usefully complex, that is, doing a lot of storytelling as well as talking about data and the kinds of results that we're discussing here. But what drives it, I always try to have a certain perspective as an author to make a book coherent, is the moment where a patient is sitting with a doctor and a decision has to be made. What do we want to inform that decision? We want awareness of data. We want our doctors to be experienced. We want doctors to know about our lives, not just about symptoms. And I think that moment is really what I'm trying to think about aloud over the course of many pages with footnotes and so on.
The patient interludes are terrific. Is there a person who really stands out in your mind who you would like to tell us about?
I want to mention a person I did not see, although I had the privilege of speaking with him, who's Ray Osheroff, his real name. And when I write this book, I talk about starting in psychiatry, and I've been practicing a long time. I started seeing patients as a medical student in the 1970s. And in those days, on the medical and surgical wards, I'm not talking even about psychiatric wards, which were more populated in those days, you would see people with a kind of terrible depression I mentioned earlier, where people were barely moving and were muttering terrible thoughts and had no hope at all. And I think we see less of that. And when I say that, antidepressants had been available for 20 years and weren't being used for those patients, people don't believe it. And I talk about this case of Ray Osheroff. He was a kidney doctor living around here. He had a practice. He owned clinics, I guess dialysis clinics. He became depressed, was put on antidepressants, given psychotherapy, did a little better, really didn't believe in the meds, came off them, did much worse, and was hospitalized here at nearby Chestnut Lodge. And the model there was psychoanalysis, and he deteriorated, and despite the pleas of his friends and family, he was not put back on medication. He became so agitated that he needed medical attention to his feet. And I spoke to him later in life, and he sent me transcripts of team meetings, kind of the meetings where doctors and nurses and so on planned the treatment of patients, and they said, oh, his wish to go back to work has to do with the fact that his rewards at work are like a giant breast, and he's, looking for the kind of warmth he never got from his father. And finally, after months of deterioration, he was kind of rescued by a friend and taken to Silver Hill in Connecticut and given medication, was better in a few weeks, was back to medical practice in a few months and practiced medicine for the rest of his life. But he lost his primary medical practice, lost a lot of money, his marriage ended, and he sued Chestnut Lodge. And that's why we know about this, because there were experts on both sides who interviewed him and reported about him. And the result of the case is complicated. I go through it in the book, but effectively he won and in a settlement, and that caused a lot of trouble in psychiatry because it caused hospital administrators to say, look, you can't just treat these patients with psychotherapy. You have to give medication. Therapists were insulted that their way of seeing things was being shortcut, and so on. And so this turned out to be an important case. But when I spoke to Ray Osheroff late in life, and he'd never had an episode of depression again like this and had been on medication all his life, he said, the literature of torture is most relevant. That this was not really, that depression, he said, is a wimp of a word. You don't understand what it was he was going through. But it really is the case that these medicines were not used on a principled basis, were not used until after that, and in a way, well after that. They weren't used regularly, even for very severe depression. So it is that kind of story that motivates the book, that worries over that sort of dismissal of these medicines.
I bet people are ready to ask you some questions. Is there anybody who would like to ask?
Dr. Kramer, I had a question about people who don't respond very well to the initial medication that's prescribed, and maybe have to try 2 or 3 different ones, and maybe there's a certain group of people who don't seem to respond to any of them. I was just wondering, is there something that you see that these non-responders have in common, or some way to kind of understand how to proceed with people that have that presentation?
Right, so the question is about non-responders. And, sadly, there are people who don't respond at all, and we have enormous need for to anything, that is to psychotherapy, medicines, combinations of medication. They're few, but because the disorder is so common, there are many of them. They're few on a percentage basis. And, sadly, for all sorts of reasons, Big Pharma has retreated from development of drugs in mental health altogether. And in the book, I write about lots of promising avenues, lots of promising avenues for research, but it's sort of mom and pop garage band sort of research where small companies try to get these attention to these potential remedies. And of course, lots of them fall by the wayside, but there aren't really the resources devoted to this problem that there should be. That said, I do also write about some interesting studies that I think the press has undercovered, and one of them was done by a consortium of universities, Rush, University of Pennsylvania, Vanderbilt, and what they did was really interesting. They took patients, and they were like the patients in the study I mentioned, fairly chronic patients well along in the course of depression, and they said to pharmacologists, do your worst. This is not normally what's studied. This was a pragmatic study. You couldn't have placebos on the other side. There was nothing comparable. They just said, raise the dose of the medicine if you want, change it, add a second medicine, add a third medicine. And half of the patients also were given very intensive psychotherapy. And although the press reported the opposite, the truth was that you didn't see a lot of effect from the psychotherapy because the medicine did so well. It turns out that if you let doctors, skilled doctors, and they were kind of senior advisors for the junior doctors in this study, really try to treat depression assertively, you get most people to respond, and you get most of them to stay well for the length of time that they looked, which was 6 months. But it took some people 18 months to get better, so this wasn't, kind of a easy process. And of course, it's also possible, since there wasn't a comparison group, that in 18 months a lot of people get better on their own. But this was a very chronic group that hadn't, on the whole, the patients hadn't gotten better on their own. So I think one lesson from that, and as I say, it's upsetting to me that I think the press really is happier to cover debunking stories that there have been, errors in assessing these medicines, that they don't really work. But the studies in which they are shown to work tend not to get the coverage that they should. And it turns out most people, almost everyone who's stuck with the program, and of course, disappointed people drop out, but almost everyone who sticks with the program really does do better and manages to stay outside of depression for a while. And even those people who didn't do well, on the whole, didn't return to their baseline of depression. It's just that they started accumulating some symptoms again. So I think things are more hopeful maybe than we imagine.
Do we have someone over here?
Yes, couldn't you preface your comments with the fact that doctors usually sit down with the patient for an hour and get the history before any medication is prescribed?
Oh, yes. Should people be well evaluated before medicines are prescribed? And, my own practice isn't just an hour. I may be with people for an hour, week after week, before we decide to give a medicine. We may know each other pretty well. But, lots of things cause depression. Early in this book, I read about someone who has a disorder of a hormonal gland thyroid disorder. And the question is whether that's causing the depression. So you need, a good evaluation that involves maybe, in addition to an interview, in the course of the interview, you may decide you ought to be giving blood tests and taking blood tests, evaluating people. People really, when we take the perspective that this is a medical disorder, which of course isn't the only perspective on depression. Against Depression, an earlier book of mine from 2005, is about how we conceptualize depression altogether. But if we take it as a medical disorder, we really have to evaluate it as a medical disorder. That said, I'm not one of these people who think primary care doctors do so badly with this. There's been an enormous effort on the part of governmental agencies and nonprofits to make general doctors aware of depression. I think they're better at assessing it, they're better at recognizing it, and that although we worry about the overuse of this medicine, on the whole, the fact that depression is getting recognized and treated is probably for the good. And I certainly find people coming to me who've only been treated, say, by a gynecologist or whatever, who come in and they say, it's not just that I'm a little better on this medicine, it's that I see my marriage differently. I see that it wasn't all my wife, that I had some contribution, that there's some loosening up of perspective, as takes place in psychotherapy sometimes, in a good response to medication. So I'm kind of on the optimistic side about a broader group of doctors using these medicines, because we simply don't have that many specialists.
Sir.
Yeah, I'd really be interested in your thoughts on some of the new rapid-acting antidepressants like ketamine that seem to have activity after a single administration.
Right.
And even some reports that they block suicidal ideation.
Right. So there's a lot of interest in a drug that was used as an anesthetic and misused as a party drug called ketamine, which is given through injections into the muscle or intravenously dripped into the veins. And it was first used in people with very severe hospitalized patients with very severe depression, and some of them got better rapidly. And drug companies are interested in this drug, and they're trying to get medicines that can be taken by mouth or can be used as a nasal spray even that would have some of these effects. And, you know, this seems like a promising treatment. I'm a little concerned that it's being used widely before it's well tested. There are some early worries that people who do respond to this after a time stop responding to it and stop responding in ways that are fairly dramatic. So we don't really yet know enough about ketamine. But as I say, there are a number of things on the horizon that seem to be faster acting, and the National Institute of Mental Health has a special pot of money that it uses to encourage research into faster acting antidepressants, because there's a lot of risk in the time between when a doctor sees a patient first and when the medicines work, a lot of risk of things like suicide and other, you know, dramatic negative acts. So we're very interested in that. That said, the antidepressants we have to hand now do things very early. I write about a doctor at Oxford in England who has used tests of perception. How do you evaluate kind of pictures in which you ought to see hopeful things, but depressed people might not? And he's given people half doses of antidepressants, and within 3 hours, their outlook changes and their self-assessment. So there are some early effects, and one of the theories about how these medicines work is that they loosen up the brain in some way, but a lot of what goes on in recovery from depression is in the world. That is, you start calling your friends again, you start putting in more effort at work, people reward that, so that there's sort of a virtuous dialectic between the chemical action and the social and psychological action of these medicines. But we do get some effects very early.
I think we have someone here.
Yeah. Could you speak to the subject of how some people have trouble taking generic forms of antidepressants, and when doctors try to write a note to pharmaceutical companies to override that, it's been my experience that more and more often they're rejected. What
Right.
is it about the generics, and I know the difference maybe between
Yeah.
the generic and the one that was originally patented, but I'm just wondering, are you aware of this as a problem? Because I see it
Yes.
quite a bit.
I mean, doctors worry when a medicine goes from the company primarily making it to a generic manufacturer making it, that the standards of the Food and Drug Administration for what constitutes equivalence are either loose, or even when they're fairly demanding, that down the road not enough drugs are retested, so that people on the generic don't do as well as they did when there was a brand name drug. On the other hand, of course, we're very worried at doctors being influenced by advertising and prescribing brand name drugs and making medical care more expensive, where generics are just as good. And the answer is there just really is not enough science on this, but every doctor sees it. You know, of course, where it's dramatic is in neurology, where a drug against epilepsy becomes generic and doesn't work as well, and people start having seizures again. You know, you see that, whereas when people kind of fade into having more depressive symptoms and become more depressive, it's not as dramatic and it's harder to know about. I think with Wellbutrin, which is a drug that works by different means, bupropion, when that became generic, there were patients who certainly said they weren't doing as well on it. I have patients who are on the brand name of Wellbutrin. On the other hand, lots of people do well on the generic. When Concerta, which is a complicated form of Ritalin that kids use because it has a certain curve of release, so it kind of covers the school day well, became generic. I noticed in adult patients that it wasn't working as well, and the pharmacist reassured me, and then the FDA did say that the generic, 3 of the manufacturers weren't doing a good enough job, and they had to sort of rejigger it, but the generic still doesn't have the same engineering that the brand name has. So yeah, we do worry about that, and it's across all of medicine, and frankly, not enough is known about it. It's hard to know what is patient's anxiety and what is biochemistry.
That supports what I've read so far, so that sounds current. Thank you.
I see situations where people say that or think that psychotherapy is ineffective or doesn't exist or is inadequate in some way. And I wonder if maybe the situation is that it's very difficult or it's often done poorly or inadequately, and it's still important to understand oneself and people in at least a theoretical way.
Right. So I want to extend this question about whether psychotherapy is always done well and whether people not doing well in psychotherapy is an effect of the expertise, say, or the match between doctor and patient, rather than inherently psychotherapy not having the potential to be effective for that patient. And I want to take this a slightly different direction, which is really antidepressants have been well tested. And there are these complicated critiques where they say, well, maybe some studies haven't been published, and we can look at the data and see a pattern that says that. And if we imagine we had all the studies, they would show themselves to be less effective. And even under those conditions, antidepressants look effective. But psychotherapy, when it's put to the same test, really does poorly. It does seem to be the case that when you study psychotherapy, when people have good results, they like to publish them. When they have bad results, they don't like to publish them. So you get a very distorted literature. That said, it's really hard to test psychotherapy. You don't know whether the doctors are well trained, and you don't have that advantage of people saying, I don't just like this therapist, I'm going to a different one. In the study, you're kind of stuck with the person you have. It's free, you're glad to have it, but it's maybe not the person you would have chosen, and maybe it's not the technique in psychotherapy that's going to work best for you. So I think that research really undermeasures the efficacy of psychotherapy, which I find, in my practice to be extremely useful and really sustaining for people, even when they do lapse back into anxiety or depression, that the psychotherapy seems to be helpful in keeping them afloat while they have a return of some symptoms. So I'm a big fan of psychotherapy, and I do think it is, very hard to measure. Lots of things in medicine are hard to measure. I mean, I hope this book is amusing as well as serious, and there are some amusing things that happen. You won't find this amusing, but there was a study of these surgical checklists, where you catechize the doctors and make sure they got all the sponges out of the patient before they close them up. There were these analyses that combined lots of small studies and showed that 60% fewer patients died when you had surgical checklists. And then finally, when they did a large study in Canada, they required everyone in Toronto to use the checklist, and researchers were able to look at what happened before and after the checklists were introduced. There was no difference at all. And probably the story was, first of all, maybe they were adopted more willingly in other places, and maybe being forced to adopt them wasn't as helpful. But mainly, hospital systems that introduced new methods and had more people die didn't publish the articles, so you had an enormous bias in the literature. And I think in general, I hope in this book I'm educating people about how to read not just technical scientific articles, but articles in the Washington Post, the New York Times, and online, or all the things that pass through your Twitter and Facebook feeds, how to read them skeptically and think, if this study had come out differently, would it have been published at all? So, yes.
I know we have a timekeeper here. Do we have time for a couple more? I'm going to go with yes. Right.
Doctor, you mentioned anxiety just a moment ago, and I wonder if you could talk about whether treating anxiety as depression is an effective way to treat it, and if you've got a very anxious person who is too anxious to take medication, have you had experience with a patient like that, and how do you address it?
So, I'm not writing much about anxiety, but the genetics of anxiety and the genetics of depression look very similar. The reasons why some people get anxious and some people get depressed are debated, but they may well be out in the world reasons as well as genetic reasons. And these medicines work well for depression. They're less addictive, and they have less of that sense of your anxiously coming off them after 4 hours than do the medicines uniquely given for depression like Librium and Valium and, in the old days, Miltown. And so doctors like to get people on antidepressants. When people are very prone to anxiety, it can be hard to get them on antidepressants because they can get more anxious in the short run, and that's very hard to tolerate. And in addition, they may be anxious about the thought of taking, maybe phobic, say, or obsessive in some way that prevents them from wanting to take medication. So that's sort of an art. Doctors use very small doses, build up slowly, but in general, these can be very good for anxiety. And an area that I also don't talk a lot about in this book is treating children and adolescents. And these medicines are less good at treating depression in children and adolescents. There may be more risk of suicide. The risk of suicide is very low, but the multiplication of the risk of suicide by these medicines may be greater in children and adolescents. And yet they are used for good reason. But where they test out very well is anxiety in children and adolescents. And it's not that I'm recommending medicating children and adolescents, complicated story, developing brain, but when children really are not reaching their developmental milestones, they're not interacting with other kids, they're not learning in school, they're not able to go to school, it turns out that these medicines are very useful in anxiety in a younger group.
Last two.
Yeah, hi there. Depression runs in my family, and we're pretty enthusiastic consumers of SSRIs and atypical antidepressants. But I had a nephew who wasn't getting better, and they did a genetic test on him and found out that he has a genetic defect or modification that affects liver enzymes that make the most antidepressants completely ineffective for him.
Right.
And he's now being treated with ketamine.
Right.
I wonder if you can comment on that and also on the possibility that genetic testing could improve the treatment of depression.
Right. So genetic testing, there already are labs that do genetic testing that say that they can increase the odds that you'll accurately select an antidepressant for someone. Largely the genetics we're talking about are the genetics you're talking about, which is enzymes and how the body breaks down these chemicals, so that if you break them down very rapidly, you may not be getting much antidepressant, even taking a lot of pills, and if you break them down slowly, you may be at risk of getting a lot of side effects, even on a low dose. But really what we want, in addition to that, is the genetics of drug response, so that when you are getting the proper dose into your brain, are you likely to respond based on your genetics? There is some of that testing. It's at a level where, over just having your doctor choose it randomly, if that were how he or she would choose it, if you gave 12 people a genetic test, you get one more response than by eyeballing it. Doctors maybe can do better than random also on their own, so maybe 1 in 12 is not enough. But I think it is in the future, and I think doctors are sometimes sending off blood samples in really non-responsive people. The Mayo Clinic, I know, does some of this. So it is available, in these refractory cases.
Okay, that seems like a good place
All right.
to finish off.
All right.
Thank you very much for being with us. Dr. Peter Kramer, the book is Ordinarily Well. Thank you so much.
Thank you. Good.
This has been a presentation of the Library of Congress. Visit us at loc.gov.